Good afternoon and welcome to another Leadership Rounds. Today, we've got a great guest with us who I've known for a long time, Mike Slubowski from Trinity Health. These are some trying times. I'm Rod Hochman. I'm, as many of you know, the chair of the American Hospital Association this year and the CEO and president of Providence on the West Coast. I think without saying, here we are, it's August 2021. We're still in the depths of dealing with COVID. I think all of us expected that this would be long over. I think all of us, stay awake at night thinking about our frontline caregivers, all of them, nurses, doctors, physical therapists, environmental service folks, dietitians, everyone that's in service to helping, curing, and taking care of everyone that walks through our doors. It's obviously been disheartening for a lot of our healthcare folks with the vaccinations and the lack of vaccinations and then the spikes that we're seeing. And particularly troublesome has been the spikes in COVID, particularly in the young. Our folks that are under 12 can't protect themselves. Our cancer patients can't protect themselves. Our folks that have depressed immune systems can't protect themselves. So we're in a desperate battle here to help protect those that can't be protected and all do our part. But I think as any one time, I think we all, as a lot of you have heard me say before, I thought there were going to be three phases, the B, C, D, C, and AC, and it was before COVID, during COVID, and after COVID. And that after COVID has been very, very elusive. But what I'd like to do today is talk with one of our health leaders about a couple of issues, but particularly about our public health structure. What are some of the things that we need to do? What are some of the lessons learned from COVID? Mike Slubowski has been in healthcare forever, Mike, right? About, 30 to 40 years. I won't say the exact number, but Mike has led one of the largest health systems in the United States. It's a Catholic health system that covers 30 states, 90 hospitals, over 130,000 people, and I think has responsibility for populations in the 30 million range. So he clearly has his hands full. And, Mike's system represents both small hospitals, rural hospitals, large hospitals, urban, but particularly the emphasis for Trinity has always been on caring for everyone, but particularly for the poor and vulnerable across. And that in this time has been particularly challenging. Mike is a leader. He's been a leader in numerous awards and colleges, which I can remember. He was a fellow chair of the Catholic Health Association and has really put in the time, was a previous CEO of some other health systems. But his work at Trinity has been just spectacular. And it's just an absolute pleasure to have you with us today, Mike.
Great to be with you, Rod. Thanks.
Good. So I'm going to, I get to, this is a lot of fun for me because I get to be the questioner here and see what Mike has to say. But Mike, the first question that I think everyone has on their mind is where is the public health system and what do we have to do and what have we learned during COVID about what the needs and capabilities are in public health?
Sure. Well, Rod, I know as you've experienced with your health system, we, in fact, have become pretty much the de facto public health system during this crisis. And, whether it's vaccinations, we've done over 1 million vaccinations, 300,000 links to social services from our medical services, doing pop-up clinics, recording information and sharing the information. And, suffice it to say, like in your situation, when we're in 25 states, we've dealt with 25 different governors, 25 different state health departments, hundreds of local health departments. And, the coordination has been a challenge right along through the whole journey in terms of, who's responsible for what, who's sharing information with who. I know that you spent some time, as I did, talking to people at the federal level about, let us help you with the vaccination program. We've set up these large at-scale capabilities to do vaccination, and then a bunch of it went to pharmacies and other organizations that weren't as efficient at getting it out there. So I think we've learned a lot about coordination and about, how to, some of the things that really would be necessary to improve public health and coordination on public health between health systems and the government during this whole time.
Right, because as you know, this is probably not going to be over anytime soon. We're going to have multiple episodes of influenza. In some way, shape, or form, Mike, with the infrastructure bill that's out there, is there some need for a national public health infrastructure? I know that's been, the problem that you've outlined, I think we've all talked about, is that every state has different regulations, different ways of approaching it. Any insights or thoughts on what we should be thinking about or advocating on the infrastructure side, particularly with the bill in Congress? And what would we ask for? Would we ask for a national standard?
Yeah, it's a great question, Rod. And, I think what we don't want to do is build more layers as a result of the infrastructure bill. I mean, I think some areas of focus would be on interoperability or on data exchange, by way of example, coordinated approach to surveillance and contact tracing, doing things like, lab and testing capacity. That we're now facing another wave of requirement with, the Delta variant that's out there right now, and some work on, education and on creating some level of clinical capacity for us to deal with these surges. So I think, there are some areas where we can be really great partners with public health and actually, either share the load or take the majority of the load on things like vaccination, by way of example. And I think the infrastructure approach and readiness for these needs to be allocated in that direction. One other, startling statistic that I heard, regarding, CDC budget, that an entire annual budget for the CDC would fund 3 days of Medicare. And the amount of the CDC budget that is devoted to pandemic support would fund 11 hours of the Medicare budget. So, I think when you put things like that in perspective, and the importance of, the CDC by way of example, I think we have to rethink our priorities on a federal, state, and local level.
Right. And I think, Mike, you and I have talked about this a lot. Our priorities, even in our own healthcare budgets, that we spend. And there's really been a lack, besides not funding public health, not funding CDC, we really haven't funded the primary care infrastructure so that, all Americans, have ongoing, preventive care, clinical care. And it's kind of been highlighted, I guess, wouldn't you say, with COVID, that so many Americans really just don't have any primary care infrastructure to go to.
For sure. The primary care infrastructure, and the thing you began the conversation with today, is how are we going to create a pipeline for nursing and for allied health professionals, which have been devastated as a result of this pandemic. And the pipeline was poor to begin with, let alone what's happened to folks with PTSD and other challenges that has come as a result of this. So to me, that's another infrastructure build that has to happen to get a pipeline of medical professionals.
Right. And I know, Mike, Trinity has done a lot on the technology side to kind of bring care closer to the home, closer to the community, and this particularly during the pandemic. Maybe, for our listeners, some thoughts that, on how Trinity's tried to solve some of those problems in the local communities and in the home.
Sure. So we have a large, home care operation. And so we have, had, fortunately, before the pandemic, we're doing a lot with technology with 24/7, 365 nurse interventions for our home care patients across the enterprise. I think, like you, the work that we did around telehealth, the very quick ramp up of telehealth to a much higher level across our enterprise has been really important. We're doing a lot now with monitoring in the home, as well as, having that access to the nurse resource. We have 2 pilots with hospital at home that we've had. We've had one in place for over a year. And, I know that people have had varying success with taking hospital at home to the next level, but we're still determined to figure out ways to do that. So, I think concern and supporting work in communities around broadband access, which is incredibly important at this time, are some of the areas that we have really spent a lot of time on. And the other thing, and I know you're an Epic shop as well, so we installed some of the modules like Aunt Bertha to connect the patients that have clinical needs directly to social care agencies that we can stay in touch with to really round out their needs.
Absolutely. And Mike, I know Trinity, you've run the gamut. What differences have you seen, or different challenges you've seen, between your rural hospitals and then your more urban and city hospitals? Have there been any differences, particularly during COVID, from a public health standpoint and some other challenges that Trinity's had to deal with?
Well, I think, the rural hospitals have had challenges right along in terms of, being able to recruit adequate both physicians and clinical support staff, and having the critical mass to support that in terms of patient load. We've done a lot of work, again, with extending our technology to them and transport for people that need support, as well as doing clinical consults virtually. So those have been areas that we've put a lot more emphasis in during this time frame. But again, a lot of rural hospitals have already, seen that actually being a hospital, there just is not the critical mass of patients or technology or clinical support to provide a broad range of inpatient services. And it's really more, immediate care, maybe holding and observation care, and then transporting people that need more intense care. And then for some that can go home, monitoring them at home.
And I think that's probably been one of the advantages that you've had as a large integrated system. And I imagine Trinity has been able to shift resources as much as you can, whether it's ventilators or PPE or staff, to help shore up, particularly for some of the rural hospitals, but for some of the other hospitals, Mike. I imagine that's been a lot of what you've been trying to do at Trinity.
We have, Rod. We were blessed in that at least a decade ago, our supply chain team developed a warehouse in Fort Wayne, Indiana. It's 450,000 square feet. And we ship to all 25 states from there. So we've been able to concentrate the buying and the logistics from that location. And it's really been a godsend for us in load balancing the needs across our ministry from a supply chain standpoint. But also, on the staffing support, in the first few waves, we were actually moving staff across the country, willing staff that wanted to support some of our surge areas. It's become increasingly harder right now. Yeah. In fact, our hospital in Fort Lauderdale right now, which is experiencing, huge challenges, we were able to get some volunteer nurses to go down to support the emergency department from Michigan. But that's few and far between right now because everybody is suffering with staff.
Because I think what we're seeing, and I know, Mike, you look at the same statistics each morning, that both overtime is through the roof, travelers are through the roof, and we're already starting to say, just the same way we look at rolling blackouts, are we going to have to, in a rolling basis, close down certain units? And colleagues have said, and I know you've heard the same thing, that it's not a question of space or equipment, it's a question of staff. Is that kind of what you've been experiencing?
Absolutely. And we started our own internal staffing agency called First Choice. This actually started before the pandemic. And it offers at least an alternative to nurses that are ready to leave instead of going to an external staffing agency, to join our internal staffing agency. And, there are people who are familiar with our systems and processes. And so, the cost is obviously higher because they're looking for the same kind of approaches that the external agencies do in terms of wages and flexibility on hours, but at least they stay part of the family.
Absolutely, Mike. The other thing that's been a real aha moment has been this whole issue around equity of care. And hasn't COVID kind of put the bright light on that? And I just would love to hear some of your thoughts on that whole issue.
Yeah, it certainly has, Rod. I mean, I think that the aspects of equity and of systemic racism have really shown their faces more during the pandemic. We've done a lot of work, as you have, with not only things like pop-up clinics, but education. We funded an effort we call It Starts Here of $1.6 million to communities to do education around, vaccine hesitancy, to eliminate vaccine hesitancy. We've done a lot more with, again, those social care referrals that I talked about. And we really took all of our community health workers and reassigned them to reaching out to people, not only for vaccination, but those that, were either suspected COVID or needed to be tested to get them cared for. But, housing, food, I mean, the fundamental issues that I know your system faces, and ours, behavioral health, another huge area that I know you've made a huge investment in, are all things that have really become apparent in terms of health equity during this time.
And Mike, what else can we do for the workforce? You've talked about mental health. What's the long-term prognosis, as we go through this for the healthcare workforce, given what we're dealing with now and then into the future?
Yeah. Well, I think the first thing is, the depiction of healthcare heroes really kind of fell off after that first wave. And I think we really need to prop up and make clear to society, the United States, the importance of healthcare workers and also, I don't think most of the public realizes how devastated and how affected our healthcare workers have been, and how we have to rebuild the pipeline and create new avenues. So I think that's one thing in terms of awareness and advocacy, as well as funding through the infrastructure program. But the other element is we need new care models. And, nursing has experimented with different care models, but I think we have to be a lot bolder about different models of using allied health professionals and volunteers and others as part of the care team to really provide a more holistic and creative way to meet some of the staffing shortages and make it attractive for people to enter healthcare through a number of avenues. We have a military vets program, and our leaders of that program feel there's a lot of veterans that were medics and things in the armed forces, and they're having a hard time getting jobs once they leave the armed forces. And they would be perfect complements to these care teams. But for whatever reason, we kind of stereotype the roles. So I think that's got to change.
As with all things, is if you can hear our gardeners out blowing leaves, it happens inevitably when we're going to do this. So I'll apologize. I'll try to put myself on mute but Mike, what about the licensing issues for healthcare workers?
Well, again, I think we've got to deal with interoperability in licensing as well, the flexibility to have people move cross states. I think we have to create different vehicles for people to get their training and to become licensed, creative ways to accomplish that. So, I think there's a lot of opportunities if we open our minds to different ways to get people trained, get them licensed, get them the ability to move across the country to support these waves that we're experiencing.
So any other words for the AHA family out there in all of our hospitals in terms of what words of wisdom do you have for all of us?
I think we have to tell our story a lot more to our communities, to our legislators at the local, state, and federal level. I think, we have to be able to share some of the experiences and the bravery that our people are exhibiting. Yeah, I think we have to be really clear on those areas of opportunity that we just talked about around infrastructure and why they would be helpful, and keep the story simple. Don't make it complicated for people. Make it something they can connect with both intellectually and emotionally. And I think in Catholic healthcare, at least, we speak a lot to the concept of the common good. And I think, we have to continue to focus with everyone we chat with about what the common good is all about and why vaccination is so critical right now. And, why we need to encourage and be leaders as healthcare leaders in getting our teams vaccinated so that they can be the guiding light for the communities that we serve. So I think there's a lot of things that our members can do. And I think our members need to be engaged with AHA. I mean, AHA has a lot of wonderful efforts on advocacy as well as healthcare transformation that we're working on. And I've really been excited to meet some really bright, committed people as a result of this pandemic that I really hadn't engaged with that much before to try to move our ministry forward. So those would be some of my thoughts.
Well, Mike, we want to all thank you on behalf of AHA and all country for your leadership, all the brave caregivers at Trinity. One thing is, I think we've all gotten closer with all of this because we kind of all understand that. But it's just wonderful having you here today and really celebrating some of the work that you're doing and your leadership in so many different areas. So I want to thank you for being with us. And I invite everyone to be with us next month for the leadership round. So thank you all, and have a good rest of the day.
Thanks, Rod.